Hi, good evening, Dr. Ari. I'm just doing a bit of housekeeping and then we'll be able to start. Wambui, just please confirm for me that what you're seeing is our ad for our upcoming mom and baby fair.
Yes, it is, Doc.
Thank you so much. Wambui, do you mind, are you in a position that you can turn on your camera?
In a minute.
No problem. So good evening, everyone. I am Dr. Aisha Bianca Edwards Remy. I am the head of clinical services at AAR Hospital. Today, I will be moderating with Dr. Wambui Wanyuki, one of our in-house pediatrician, who will turn on her camera and introduce herself to you guys, as you've been hearing her voice over the last couple of weeks. Today, we'll be tackling colorectal cancer, the management of colorectal cancer, as the month of March is Colorectal Cancer Month. Our presenter for today is the one and only Dr. Paul Odula, who I'm hoping will turn on his camera. So Dr. Paul Odula is a general surgeon and laparoscopic surgeon. Hi, Dr. Wambui. So at least so that guys can see you, and then at some point you can turn off. So Dr. Paul Odula is a general surgeon and laparoscopic surgeon. He is a lecturer at the University of Nairobi. He is the honorary head of surgery at AR Hospital and practiced at some of the leading hospitals here in Nairobi and by extension, Kenya. So Dr. Odula will be taking us through today the management of colorectal cancer. Thank you, Dr. Ari. Welcome, and I hand over to you. Please allow me to take off my camera. Dr. Wambui, it's up to you if you'd like to leave your camera on.
Good evening again. My name is Dr. Paul Odula, as Dr. Aisha Edwards has introduced. I'm a general surgeon with a special interest in laparoscopy, and I also operate in other general surgical areas, like hernias, goiters, hemorrhoids, etc. But today, our topic will focus on colorectal cancer, and to guide us in this discussion, my first slide has some of the common FAQ questions or frequently asked questions that I'll use to discuss this important subject. Some of the common questions that you tend to ask or you tend to hear is, what is colorectal cancer? What is the epidemiology? Why is there a rising incidence of colorectal cancer in Kenya? How does it develop? And what are the risk factors? What is the clinical presentation? How do you investigate it and stage it? How do you treat it? In this particular regard, we'll focus on colon cancer. And most important, of course, is how can you avoid getting colorectal cancer? In other words, also, how can you screen for it? So without further much ado, we can go straight to the question, what is colorectal cancer? As we all know, basically cancer, it basically just means cancer that develops in the colon. The colon, by that we mean the bowel or large intestine or rectum. Anything which arises from the large intestine or the rectum is called a colorectal cancer. The colon, as you can see in this slide, is about 5 feet long and extending from the cecum on the left, the ascending colon, right hepatic flexure, the transverse colon, left flexure, descending colon, sigmoid before reaching to the rectum. Beyond the rectum is where you have the anal opening. So any cancer that occurs within this large intestine is deemed as colorectal cancer. What is the epidemiology of cancer? And specifically, we try to focus on colorectal cancer. The top 3 cancers that killed the most people worldwide in 2020 were: number 1, lung cancer. Lung cancer killed over 1.8 million people worldwide. Colorectal cancer was number 2 with 935,000 deaths. Liver cancer was number 3 with 830,000 deaths. And in Kenya, cancer is actually the 3rd leading cause of death. This is after infectious diseases and cardiovascular diseases. When you look at specifically which are the common cancers, the 5 most common cancers in Kenya in 2020 were in order: breast, cervical, prostate, esophageal, and colorectal cancer. Did you know that colorectal cancer is the 4th leading cause of cancer deaths in Kenya? Well, if you can look at these graphs, figure 1 on the left, basically it's just representing the top 10 cancers in Kenya. You can see colorectal is number 5. Figure 2 shows the ones that causes death. Colorectal cancer is number 4. Below, figure 3 and 4 just shows that predicted trends with regards to cancer deaths between 2020 and 2040. Colon cancer accounts for 1 out of 10 cancer deaths every year worldwide. But it's not so bad. If you look at all the cancers, cancer is the best survival rates. Colorectal cancer is still the top 5 cancers that have the best survival rates worldwide. So all is not lost when it comes to cancer. Why is there a rising incidence of colorectal cancer in Kenya? Is it because there's an increase in life expectancy? Could it be because we have adopted a lot of unhealthy lifestyles, the so-called Western type of lifestyle, diet, and activities? Or is that because of an improvement in the diagnostic capabilities for detecting cancer? Well, is it one of these or all of them? We'll try and go through this in our discussion. You can make a decision on which one you think has played more of an influence in the rising incidence of colorectal cancer in Kenya. So how does colorectal cancer develop? In other words, what are the risk factors that need to be considered also when you're thinking about how it develops? Usually develops as an uncontrolled abnormal cell growth, which starts in the colon or the rectum. These abnormal cells will form a mass of tissue. Initially, it starts as a non-cancerous polyp, which with time becomes a cancerous tumor. You may ask, what's a polyp? A polyp is just a growth that shouldn't be there. Most colon polyps are harmless, but over time, some can actually develop into cancer, which can become fatal, especially when found in the late stage. 3/4 of all primary colorectal cancer usually have a benign adenoma, while over 95% of histology of these colon cancers are so-called adenocarcinoma. So this is a very important slide. It shows how a polyp can grow to cancer within 10 years. In red, I've put it in bold. It's an opportunity for intervention. So you can just have a normal colon, then it undergoes some mutation to form a polyp. This polyp will grow slowly, then will undergo another mutation, genetic mutation, before it starts forming early colon cancer. You can see the distance between early and late is short compared to the 10 years. This guides us and tells us that if we can get the polyp early, and there are many opportunities in 10 years to get it early, we can be able to prevent colon cancer. So what are the risk factors? Different cancers have different risk factors. But having a risk factor does not necessarily mean you're going to get cancer. Certain risk factors increase a person's chance of developing a polyp or colorectal cancer. The risk factors that are very important, I can mention a few. Most of them are lifestyle factors. For example, a diet rich in red meat, that is beef, pork, lamb, or liver, or processed meat, is a very important risk factor. Cooking meats at high temperatures, like frying or boiling or grilling, is an important risk factor. Physical inactivity, obesity, just by being overweight, smoking, and heavy alcohol use. Other risk factors: age over 45 years old in Africans, a personal history of colorectal cancer or polyps is a risk factor, a history of inflammatory bowel disease. Sometimes you hear people having IBS, sometimes can be included in this group. A family history of polyp or colorectal cancer, inheritance syndromes, which are seen in certain races, like Jewish people of Eastern European descent. Type 2 diabetes is a risk factor. And infection with schistosoma species like Sinensis can make you have a high risk of developing colorectal cancer. Now, what can you do to reduce your risks of getting colorectal cancer? There is evidence, mounting evidence to show that diet rich in vegetables or having regular physical activity can actually reduce the risk of developing colorectal cancer. And this evidence seems to be convincing. In addition, diet rich in starch or non-starch polysaccharides, which have fiber and carotenoids, all are said to possibly reduce the risk of developing colorectal cancer. Aspirins and non-steroidal anti-inflammatory drugs have also been studied and found to reduce the risk of developing colorectal cancer. What is the clinical presentation of colorectal cancer? And to be more specific, what is early disease and what is more advanced disease? I'm sure in our audience today, we have people who, the public, who may not understand all the terminology, so I'll try to be as simple as possible. What are the signs and symptoms of early disease? They may just be asymptomatic, may just be going along your normal day-to-day activities and not aware that actually you're developing colorectal cancer. Some people actually feel weak and usually easily get fatigued. Some of this could be because of loss of blood. HP may drop without their knowledge. Some even just lose weight. So one has to be very careful and don't assume that some of your weight losing measures are working very well. But yeah, whenever you see suddenly weight loss which can't be explained, it's good to start going for a checkup. Now, for more advanced disease, patients usually present with blood in the stool. Some of this blood may not be red, may be looking dark. The patients usually complain of a change in bowel habits, or you'll tend to feel like you want to go to the loo, but you're not really going. Cramping can actually occur. Usually when you have cramping, either you develop intestinal obstruction or there could be a perforation somewhere. When you examine these patients, you tend to notice that they have abdominal tenderness. You may actually see the blood in the stool, or when you're doing a rectal exam, you may actually palpate a mass, abdominal mass, may have an enlarged liver, or even just frank ascites, that is a lot of fluid in the tummy, making the belly look really large. So how do you investigate and make a diagnosis of colorectal cancer? This is a diagram just showing the various part of the large intestine and how it would look like through a colonoscope. Usually when you look at colorectal cancer, we try to find out which is the commonest location of this cancer. Over 50% of the colorectal cancer tend to be found in the rectum and the rectosigmoid junction. 25% tend to be found in the sigmoid colon, and the remaining 25% found in the rest of the colon. That is the cecal, ascending, transverse, and descending colon. So what are the principles of doing a colonoscopy or doing laboratory studies? When you do a colonoscopy, usually you're able to visualize the polyp or the colorectal cancer and be able to take a specimen for tissue diagnosis. Laboratory studies usually are just done to assess a patient's organ function, be it the liver or the kidney, and also in anticipation of diagnostic and therapeutic procedures, and also to try to estimate the tumor burden. And likewise, the principles of imaging is mainly for staging purposes. When you do images of the chest and abdomen, preoperatively, you're able to gauge the extent of the disease. Any other further workup using imaging depends on the clinical setting. For example, your patient presents with profuse bleeding or perforation or obstruction. Usually this patient will require emergency surgery and the relevant imaging that is available. Also depends, some patients may have comorbids like diabetes or hypertension. You need to consider that when you're doing your imaging or test. So the common blood studies that we do are the complete blood count, look at the blood chemistries, and trying to check on the organs and the various micronutrients, liver function tests, kidney function tests. You do the tumor markers, that includes serum carcinoembryonic antigen CEA levels, and also the serum CA19-9 levels. These ones can actually give you an indication that something is happening. They're not very specific, but they're more useful usually on follow-up during treatment. The latter two, that is CEA and CA19, are more useful when you're following up your patient after diagnosis. The imaging studies that are commonly done include abdominal pelvic CT scan with contrast. We also do chest X-ray or a CT scan chest, preferably. An MRI can also be useful to image the abdomen and liver for purposes of staging. PET scan, PET CT scan is also very useful and it's highly sensitive image test which can guide you on how far or the different types of metastasis the tumor could have gone to. The other tests that can be done, which are becoming more and more prominent nowadays, include the stool tests, the FOBT, guaiac-based fecal occult blood test, the fecal immunochemical test, mutations and hemoglobin in the stool. And it's become very popular nowadays as a screening tool, and is is getting more patients prefer this compared to colonoscopy, because colonoscopy sometimes can be quite challenging to patients. The blood-based tests include the epiprocolon. This is the qualitative in vitro assay for detecting methylated septin 9 DNA, which has been associated with occurrence of colorectal and plasma obtained from whole blood specimen. So colonoscopy has remained and still continues to be the gold standard in getting a definitive diagnosis of colorectal cancer. Basically, it's a flexible tube with a light inside, so you can look into the intestine. You can take pictures, take biopsies, and even do a bit of therapeutic maneuvers if there's any bleeding. The newer alternatives of colonoscopy include a pill cam. These are the pills you can swallow, which has a camera in it, and it moves through the intestine taking pictures. And these pictures which are acquired are transmitted to a recording device and converted to a video format, and you can view it on your computer. This is just a slide to show the different types of polyps colonoscopists might see. You may see a sessile polyp in that picture on the left. In the middle, you can see a polyp with a biopsy forceps trying to biopsy it. On the right, there's another type of polyp also with a called tubulovillous adenoma. Tubulovillous adenoma. Another type of adenoma. On the left, the tubular. On the right, the tubulovillous adenoma. And in that picture in the center, at the bottom, you can see the polyp actually being removed with the biopsy forceps. This is a clean colon showing a pedunculated polyp, a polyp which keeps twisting on itself. How do you stage colorectal cancer, and what does staging mean? This is just a slide to show how the normal colon looks like under a microscope. You can see it has the layers, a mucosa, a submucosa below, just beneath the mucosa, a thick muscular layer, a serosa, and a subserosa, just deep to the serosa. So for you to stage the cancer, you want to see the cancer usually starts in the mucosa and spreads inwards. Depending on how far it spreads and how much it spreads to neighboring nodes or structures, that's how we're able to stage the cancer. That's how you can decide whether it's early or late. Here's a slide which shows this more illustrates much better than the other one. You can see stage 0. The tumor is just localized in the mucosa. Stage 1 is starting to penetrate the mucosa. Stage 2 is actually reached a muscle layer. And stage 3 is gone beyond. When you compare stage 2 and 3, if you notice that those lymph nodes at the top, the white ones, those ones are not affected. But in stage 3, they actually started being affected. By the time we're reaching stage 4, the cancer has gone beyond to the blood vessels and spread to other organs. So this picture, this slide, graphically just summarizes to tell you how we stage colorectal cancer and what you mean by early and late. So stage 0 to 2 is considered early cancer. On that, you can know that it's not gone to the lymph nodes and there's no distant metastasis. But stage 3 and 4, it has gone to the nodes and even gone beyond. That is late stage colorectal cancer. This one slide showing this Tnm staging that we use, the 8th edition publication, where T stands for the size of the tumor. And we look at the size and how far it has grown from T1 all the way to T4. N stands for the lymph nodes involved from N1 to N2, and even N1 as A, B, and N2 as 2A and 2B. N1 goes to C, sorry. Then M stands for metastasis, how far it has metastasized from M0 to M1. And M1 is 1A, B, and C. So once you get all those together, you can put them and you can actually even break them down. Instead of stage 1, 2, 3, 4, 2 can have 2A and B, 3 can have A, B, and C, and split it up in that fashion. This seems to be a more acceptable, accurate way of staging nowadays compared to the previous one, which is using a 5th edition. So how do you treat colorectal cancer? Do you have to operate on any patient colorectal cancer, on all patient colorectal cancer? The treatment will focus on colon cancer, Colon and rectal cancer treatment is slightly different, so won't dwell into rectal cancer. We'll try to just focus on colon. Where there are important differences, I'll bring them out. So for the timing, surgery is still the only curative modality for localized colon cancer. That means stage 1 to stage 3. Surgical resection not potentially provides the only curative option for patients with also limited metastatic disease in the liver or the lung. So you can actually go in and remove the mets and help the patient liver, prolong the patient's survival. This is a slide showing the various kind of standard colectomies we do. You can actually do a right hemicolectomy, a left hemicolectomy, remove the left colon, or a sigmoid colectomy. We just remove the sigmoid colon. We also do total colectomy. Sometimes we have to do that for patients who may have certain conditions that predispose them to colorectal cancer. In this case, we remove the whole colon. You can see the picture on the left and connect the small intestine, that is the ileum, to the rectum. It's called an iliorectal anastomosis. These are patients with hereditary non-polyposis colon cancer, or those who have this polyposis familial, or metaclonus cancer, separate colon segments, or we have a malignant colonic obstruction and non-status of proximal bowel. Chemotherapy for colon cancer. Chemotherapy or post-op is used for selective patients, post-op chemotherapy. So we used chemotherapy for stage 2 colon cancer who are at high risk of recurrence. It is standard for patients stage 3 cancer, and of course also stage 4. We only use neoadjuvant meaning giving chemotherapy before surgery for people who have metastatic colon cancer in an attempt to convert an unresectable isolated liver met to a resectable liver metastasis. And in this case, that's why I just thought I can just mention rectal cancer. Neoadjuvant chemotherapy is actually used quite freely. Any patient who presents with poor histology, that means a very aggressive tumor, or they have extramural spread as evidenced by MRI, or patients who have involved nodes shown by endoscopic rectal ultrasound, or they have extramural venous invasion shown by MRI, would benefit, usually are given neoadjuvant chemotherapy, unlike in colon cancer. The classes of drugs or agents used for chemotherapy include, or for treatment, includes cytotoxic drugs, as listed there: 5-fluorouracil, irinotecan, oxaliplatin, and drugs like oral fluoropyrimidines are very useful in treatment of colon cancer. Biologic agents, which are listed there, also act as targeted therapy based on genetic analysis of the tumor. More recently, anti-angiogenic agents are being tried out, and we've yet to use them widely. Newer treatment modalities usually come from development of these newer targeted therapies. And by integrating this systemic therapy with surgery, radio, liver-directed therapies, we can hopefully get a better control of this cancer. But may I remind you that surgery is still the most definitive treatment modality. And these treatments are just basically to improve the cure rates for those early stage, and also to prolong survival for those with stage 4 disease. The 5-year relative survival rates in the US show that localized disease, over 90% actually, able to survive 5 years. And regional disease, 71.8%. For distant diseases, actually drops to 14.3%. So how do you avoid getting colorectal cancer? What screening methods are being used? Screening is very important. Colon cancer is actually preventable. By making an early diagnosis, there's a better chance of successful treatment. If you can get regular colon cancer screenings, That means if you get any polyp and you remove it or abnormal growths, you're as good as cured. So who should be screened? The American College of Gastroenterology Professional Medical Organization actually recommends that all African Americans begin colon screening at the age of 45. This is in contrast to for the Americans who are not blacks. Usually they started screening at 50. So there is an age difference between African Americans and white Americans or Caucasians. So people at average risk, basically anybody who is between the age of 45 to 75 are at average risk. I'm talking about in our setup in Kenya, anybody between the age of 45 and 75 at average risk. And once you reach the age of 75, we advise you discuss with your doctor if you need to continue on screening. And this includes men and women. Then there are those who are at high risk. If you have one or more risk factors for developing colon cancer, which I'll show later, the various risk factors, then you're at high risk. This includes patients with people with personal or family history of polyps or colorectal cancer. The different types of cancer screening tests we already talked about: the stool test, the DNA, stool DNA, colonoscopy, and sigmoidoscopy. So usually suggest for people with average risk, those with average should do a stool test every year, and they're straightforward. Should do a stool DNA every 3 years, colonoscopy every 10 years, and for sigmoidoscopy every 5 years, combined with the stool test above. On its own, sigmoidoscopy is enough. So the summary of the colon cancer risk factors, they can be divided as modifiable and non-modifiable. Modifiable means you have the opportunity to modify them, while non-modifiable are the ones where no matter what you do, you can't really change much. Excess weight, that one we know is a well-known risk factor. Sedentary behavior, this goes well with our lifestyle nowadays. We tend to walk, we don't walk around, we tend to drive around, take lifts. Red meat and processed meat, I've already talked about. Smoking and alcohol. These are all things which are within our reach. We can modify to change our risk of developing colorectal cancer. The non-modifiable factors are those which are family history, inherited diseases, inflammatory bowel disease like Crohn's disease, ulcerative colitis, and also race and ethnicity. They're those who are always at a higher risk of developing cancer compared to others. Majority of these cancers and deaths could be prevented by increasing awareness and screening according to the recommended guidelines. Thank you. It's a nice slide I just put at the end that it's quite interesting when you see people arguing about a lot of myths about cancers, but like in this picture, you can read for yourself. You have two options. Either you follow evidence-based treatment or try the exciting, risky alternative. Thank you very much. I'm open to comments and questions. I'm sure I have some colleagues here who can add or comment on one or two things. I try to be as simple as possible so that people don't get lost on what is important. Thank you.
Thank you very much, Dr. Terry. So as we get ready to answer questions and field questions, anyone who is attending this webinar and would like to ask a question, there are three modes by which you can ask your question. So you can raise your hand, you can put your question in the chat box, you can put your question in the Q&A section. It is important to note that this webinar is happening live on Facebook, and therefore there are also questions that are coming from that area. I think one of the things that I think about when we talk about colorectal cancer, there's a time that the people who you knew who had colorectal cancer was, for example, the Queen's mom who died from colorectal cancer. Pele, the footballer. There's a guy by the name of Marshall, who was a cricketer, but recently everyone knows that Black Panther died from colorectal cancer. And I think when that happened, there was a drive or an awareness to get that, for you to get yourself checked, because he was 43 at the time that he died in 2020. So Dr. Wambui, I will turn it over to you. I don't know if you have any questions in the chat as yet. As we get started, Patricia, the same thing applies to you as you look for any questions in the Facebook forum.
Okay, so my first question, I'm not sure if it was covered. The question is, after surgery, how frequently is a colonoscopy done?
Right. Usually we recommend after surgery, you do at least a colonoscopy 1 year later. But it also depends on how the colonoscopy went. Sometimes you have a situation where during colonoscopy, you find the tumor, you're not able to go beyond the tumor. They recommend within 3 months after surgery, you go back to check the proximal colon. Others might be exposed to developing another tumor proximal to that. But usually annual, 1 year after resection. Thanks.
Thank you, Dr. Patricia, any questions on your side before we go back to Dr. Wambui?
Yes, I do have a question. What is the difference between colon cancer and colorectal cancer?
As I explained earlier, and I showed the anatomy of the colon, basically the colon and rectum are different. The rectum is found distal to the colon before you reach the anus. So we tend to call them together, combine them as colorectal because they tend to behave in a similar fashion. So it's a colorectal cancer, but they actually, when you look at them, their treatment is actually slightly different because they behave different. They respond differently to the treatment. So sometimes people just talk of rectal cancer, stick it to the rectum. That's understandable, it's there, or colon cancer, but we tend to clump them together as colorectal cancer.
So, Doc, another question that is coming forward is, should I be concerned if I pass blood in my stool? Is this a sign of cancer?
There are many causes of passing blood on the stool. What you need to do is look at yourself. Are you average risk or high risk? So if I talked about those who are between 45 and 75 are people of average risk. That means there's certain things they need to do in terms of colonoscopy or screening measures they need to follow because they're average risk. But if you're not the age of 45, of course, you have to consider many other factors. Infection can cause bleeding, hemorrhoids, fissures. Anal fissures are very common. So that does not mean that you can't have cancer, but yeah, provided the bleeding is painless, you need to have a high index of suspicion. Thank you.
Dr. Wambui, any questions on your side?
Yes, there's a question here from one of the general surgeons asking Dr. Odula, what is your personal experience on surgical options of ELAPE versus APR? Comment on ELAPE morbidity.
ELAPE stands for extra elevator abdominal perineal excision. It's a new surgical technique for low rectal cancer, more radical than the conventional abdominal perineal. They say it has better oncological outcomes. Personally, I've not done ELAPE. I've just done APR. And most of the time, patients come when they're late. So even then, by the time you go in, you want to do an APR, it's a bit late. So you end up just doing putting a colostomy and getting a diagnosis. But yes, I don't have experience with that. Maybe Dr. I think I see Dr. Siboy around. He can make a comment on that.
Thank you, Dr.
Dr.
Odula.
Siboy?
I agree with Dr. Odula. It's relatively new in terms of procedure-wise. I also don't have experience with it. But I mean, the evidence is still not good to say that. I mean, and the evidence out there is not showing to be superior to APR. So for us, the standard procedure for lower rectal cancers is still abdominal perineal resection. Whether you do it open or laparoscopic, I mean, is what you can discuss. I also don't have any experience with ELAP, as it were. That's a good question, Dr. Magari. Maybe you can tell us, maybe you're performing them in Nakuru.
So Patricia, while I try to unmute Dr. Ari so he can give us his experience, is there any question on Facebook that you'd want to have us look at?
There's one last question where somebody's asking if back pain is one of the symptoms for colorectal cancer.
Sorry, go ahead, Mark.
Just as the presentation and the presenter highlighted, it has to be taken in the context of other symptoms. What are your other symptoms that you've presented with? So my advice would be that the client would need to go and get examined. It may be related to just simple back problems, or it may be something else, especially if it has been long-standing. The best advice you'd give that person is to go and get seen in a facility, get examined, and a good history is taken so that you're able to determine. The short and long answer is, if it is advanced disease, colon cancer can also spread to the bone, and it may be, but it has to be taken in the context of symptoms and examination findings.
Thank you, Dr. Ari. Dr. Benjamin, I believe you can unmute and give us your experience.
Okay. So far, we haven't done much on, we haven't done the lap on this side of town, this Nakuru town. What we also been doing the APR. But I just wanted to know about the experience of the lap if you have, and would have done, because like in the West, they tend to be saying there's a better option, though with a fairly high mobility in comparison to APR.
Thank you, Dr. Ari. So I think then Dr. Siboy and Dr. Odula will be looking forward to who actually does one, and then maybe they can give us their experience thus far. Dr. Mbui, allow me to throw it back to you. Are there any questions on your side?
So another question from one of the participants: what determines a patient getting a colostomy? What factors are there?
Maybe I can attempt this. One, it depends on the initial presentation of the patient. So if they come as an emergency, and for instance, you find that they have obstruction or they're blocked, so that nothing is passing through the large intestine, and they come as an emergency, you may need to temporarily put colostomy or divert the large intestine so that the stool comes out through an opening on the abdominal wall. That's usually the most common indication. Number two, it may be done if you have, if the tumor is low in the rectum. If it's low in the rectum and we have to essentially remove the rectum, so you have to give the patient an opening for stool, so you give them a permanent colostomy. Number three, it may be done as a stopgap measure, so that the patient undergoes neoadjuvant therapy and radiotherapy, try and downsize the tumor before definitive surgery. Thank you.
A question being asked is how often after age 45 should one get a colonoscopy? Is it something that is done yearly?
All right. The data that we seem to be having, I mean, the Western data seems to suggest we talk about 45 and 50, but we are seeing younger cancer being diagnosed in a younger population, especially I think in Kenya and in Africa at large. I think there's a publication by the late Professor Saidi et al. Published in the Annals of Surgery, African Surgery, showing that we are having a younger and younger population. So to answer that question specifically, it depends on whether you have any risk factors. If you have any family history of patients or family members who have colon cancer, and the rule of thumb is 10 years younger than the diagnosis, you should start screening. Number two, if any abnormality was found in your last colonoscopy, your doctor would ideally advise how soon after they would need to do the colonoscopy. In the case of patients who've had or been diagnosed with colorectal cancer, number one, it depends on whether you did a complete colonoscopy. If you didn't do a complete colonoscopy, as Dr. Odula had suggested, a complete colonoscopy should be done within 3 months. If it was completely done within a year, then you also follow it up with the blood markers, the CEA level, or the blood tests, which are still, I mean, quite expensive. I think the most common ones which are still being done are the Y positive occult blood and the FIT stool test. So it really depends. It depends patient to patient and depending on what was actually found and the symptoms that they have.
Thank you, Dr. Ari. Patricia, on your side, and Dr. Wambui, any questions that are coming forward?
Dr. Aisha, on my end, there are no more questions. I'll push it back to Dr. Wambui.
Okay, Doctor, I don't know if I'm late. I wanted to ask Dr. Siboya and Odula, what's the experience of use of stents, especially in emergency setting as a temporary measure?
Dr. Odula, maybe you can pick that one up.
I think Dr. Siboya does a lot of them. Mark?
In colorectal cancer, again, depends on the presentation. If your patient comes with complete obstruction, I really don't think there's a role for a stent. But if during routine colonoscopy, and you find a tumor that is nearly obstructing, there are those who opt for temporarily putting a stent to allow further investigation. However, there are studies coming out showing that these stents seem to be affecting neoadjuvant, especially neoadjuvant chemotherapy and radiotherapy. So really not too many people are putting colonic stents. As I mean, we all know surgery is has best survival outcomes. If you get it early, surgery has your best chances of long-term survival. So very few indications for colonic stents, and most of the ones done tend to be on the left side rather than on the right side of the colon.
I think if you can add on that, yeah, in cancer, I know stents are used a lot, especially esophageal tumors, and most of those advanced cancers, and you're just trying to allow the patient to feed, but there's nothing much you're doing. But in colon cancer, usually more aggressive, like Mark has said, very aggressive. Get it out, resect, put a colostomy, or then start adjuvant therapy. And if there are any mets, go for them, get them one by one, because the more you get out of the tummy and do adjuvant therapy, the longer the survival for the patient. So we're more aggressive. We don't want to use temporary measures like stents in colon cancer. Thanks.
Dr. Wambui, on your side?
No questions at the moment.
Okay, so there's one question being asked here. The question is there a correlation with colon cancers and other form of cancer or malignancy?
I can't say I've seen any correlation, but what we're seeing, and this is lately, I'm seeing where you're having two cancers in one person. I've had the past 1 year, I've seen two patients who One came initially with breast cancer. We did mastectomy and chemotherapy, and 3 or 4 months later, they presented with colon cancer, and we had to go into a right hemicolectomy. The other one was the other way around, came with colon cancer, and 1 year later, they developed breast cancer. So I don't think there's any correlation, but maybe the body or immune system are more predisposed to cancer. I don't know how or why, but those are the few that I've experienced. But in literature, colon cancer, ciliary cancer, I'm not too sure. Unless Mark has come across something. Mark?
I don't know the background of the person asking the question, but I think maybe they may be alluding to Lynch syndrome, whereby because of changes in the DNA, you're predisposed to certain types of cancers. So patients who have Lynch syndrome may have endometrial cancers or ovarian cancers or similar types. Now, the shortfall that we have is we don't follow up in terms of DNA or the immune markers to find out whether these things are hereditary. So we'll be better able to answer those kind of questions if we are able to do some of these tests. But most of the patients are just happy once you've sorted out the cancer. They don't want to pursue the immune studies to find out whether it is hereditary or not. But there is an association in terms of colorectal cancer with some other cancers. Yes.
Mark, maybe can you comment also on familial polyposis as an increased risk for colon cancer in families? And is there a dominance in terms of male relatives, or it does not spare by gender?
Familial adenomatous polyposis is hereditary and will 100% result in cancer with no certain terms. It's just the way we use the analogy of breast cancer. Patients who have BRCA1 or 2 are very likely to develop breast cancer. In colorectal cancer, if you have familial adenomatous polyposis, which have multiple small polyps in the colon over 100, you will, without shadow of doubt, develop cancer. And the treatment of that is usually removal of the entire colon. It does not separate male or female gender. So all patients who've been diagnosed with familial adenomatous polyposis are advised to tell their relatives to get a screening colonoscopy, and also their children from a young age. It will eventually result in colon cancer.
Okay. Thank you very much, Dr. Siboy and Dr. Dula. So Dr. Siboy, thank you for just joining in and answering questions and providing some clarity. As I start to wrap up, let me first ask Patricia again, do you have any questions on Facebook? And the same question goes to Wambui. Are there any further questions in the Q&A section or in the chat?
On my end, Dr. Aisha, there are no further questions from social media.
Okay.
Thank you.
On the chat, I think the last question for genetic syndromes in families has extensively been covered, so no more questions on my end.
Thank you so much. Before we wrap up, I'm seeing that Ms. Naomi Wambugu, our head of nursing, is on this webinar today. So I'd actually invite her to unmute her mic and just tell us about the flyer that we're seeing for the upcoming Mom and Baby Fair.
Thank you, Dr. Aisha. Thank you, Dr. Odula and Dr. Mark, for the beautiful remarks and presentation. We have an upcoming event of Mom and Baby Fair, and we aim to do it every year. We had one last year, and this quarter we have planned one in April. It's the coming Saturday of 2nd April 2022. It will be an event bringing together moms, expecting moms and mothers with young babies who will be able to interact with our obstetricians and pediatricians, our nursing midwives, and other teams on board, like the nutritionist. I urge all the consultants who are seeing these patients, you can send us on Saturday to visit our facility, and we'll be able to have a good interaction and share a lot of information in creating awareness. We aim also to take them around the hospital so that they can see our maternity suites, and hoping that they will be able to buy into our services and become potential patients. We look forward to work together, and any information that will be upcoming, we will be able to share with you. We thank you so much for your partnership and continued support for our services. Thank you very much and good evening.
Thank you so much, Naomi. So if you are a clinician, if you're a patient, if you're watching this as a delay video on Facebook, please note, as Naomi mentioned, Saturday, 2nd April 2022, 9 a.m. to 12 noon, AR Hospital, Otago Road, opposite Karura Forest. There will be a mom and baby fair. It's important to point out that Dr. Mark Siboy has a clinic that runs on Wednesday afternoon and Thursday morning. If you are concerned and want to check with a surgeon for a review, Dr. Dula, maybe you can tell the guys who have logged in, or those who may be listening to this recording as a delay recording, when your clinic is at AR Hospital.
Yeah, I usually come to AR on Thursday afternoons. If you want to book an appointment, you can just book with AR and I should be there, be able to discuss with them further in case of any issues concerning whatever symptoms that they've come across and guide them accordingly. Thank you.
Thank you very much, Dr. Ari. So Patricia and Dr. Wambui, thank you so much as usual for helping to moderate this webinar. To everyone who logged in, we truly appreciate your continued support. We look forward to seeing you next week, Wednesday, as we look at a gynae case, and we'll discuss that. And I'm sure Patricia will put it out in good time so that we can all log in. So thank you again for supporting us. Thank you to our speakers for presenting today. Do have a good evening, and we see you next week, Thursday, same time, same place. Good evening, all.
Thank you. Bye.
Bye.
Have a good evening.